TopMedTalk.
Hi, it's Desiree Chappell here and the TopMedTalk team. I hope you're staying safe during these times. We wanted to say thank you for downloading TopMedTalk. This piece is not specific to the COVID-19 crisis, but we are covering it daily. If you want more of that information, you can find it on TopMedTalk.com. Now, in the meantime, we are continuing to champion perioperative medicine like we always have done. And we're working with our academic partners as the crisis continues to bring you our normal scheduled content. We also want to say thank you to our sponsors, specifically Edwards Life Sciences, for their generous support. I hope you enjoy this podcast.
Hi, it's Monty Mythen here, Editor-in-Chief of TopMedTalk from the Queen Elizabeth Centre in central London, where we've been attending a special dinner event funded by GE Healthcare at the Association of Anaesthetists Winter Scientific Meeting. Whew, got that one out. Now, with special guest Marcus Peck, and the last time that myself and Desiree Chappell, hey Desiree.
Hi Monty.
Hey. Met Marcus was here.
In the QE2.
In the QE2, but at a different meeting.
I literally came over to say hello to you, because I haven't seen you for a few years, and you said, sit here and put these on.
And chat away.
He literally said, stick these on.
We were in.
No, I have to ask, how do you guys know each other?
Oh, Monty, I met you as a medical student.
Oh, really?
Yes. Yes.
It wasn't that long ago.
It was.
I was a medical student?
No, I was a medical student. You were a consultant. And it was you and your colleagues that made me interested and passionate about critical care. This is why I'm here.
Excellent.
Oh, my God.
So it's such a pleasure to be hanging out with you, talking about this stuff.
Well done.
Yeah.
Fantastic.
Cool.
I won't say how long ago that was.
No, we won't talk about
Yesterday.
that. The hospital doesn't exist anymore, actually. Say that.
Wow.
Now, you can listen to your previous conversation, listen to our discussions tonight at the dinner venue. I thought it was great fun.
It was a wonderful event, lots of engagement. And I mean, Marcus, you and Matt Wiles and Jez von Schwanenberg.
Really great engagement. You can hear the buzz in the background.
Yeah.
You can't get the people out the room.
No, they're still sitting here.
But a great. Now, we touched on a whole broad range of areas, but there was a lot of talk about ultrasound, which you're passionate about, Marcus. Tell us about your ultrasound roles.
So I co-chair the committee that runs the Intensive Care Society FICE committee, Focused Ultrasound for Intensive Care. And we've been running echo and non-cardiac ultrasound training for about 8 years or something like that, 7 or 8 years. And it's been really great to be involved in something that's been growing at such a rate. And our mission is to make sure that everybody in intensive care can learn this stuff wherever they work and practice wherever they are. That's our campaign.
Desiree, you're a nurse by background, trained as an anaesthetist. Do you get to do ultrasound?
Yeah. Not too much of the POCUS stuff. But we've been trained, for lines now. It's the standard, gold standard to use the
for intervention.
Ultrasound for. And anytime we can do TTEs. We've been trained in transthoracic.
Fantastic.
And, I use the ultrasound a lot, like putting in IV line, IV. Simple.
Looks difficult. Let's just go for it.
I mean, we have a lot of patients that are really difficult sticks.
Yeah.
And just for patient comfort, if I stick one time, if I can't get it the first time, then I'm like, I'm just going to go to ultrasound because we don't need to put the patient through this. So something as simple as that has been, it's changed practice really for us.
I watched, do you sometimes think that there are some aspects of ultrasound that you don't belong to or that belong to someone else? Do you feel that sometimes? I'll give you an example. When I was new consultant, I always kind of thought I knew a lot about cardiac ultrasound, but I thought that below the diaphragm that was someone else's job. That was emergency medicine because it's fast scanning. It's I was never going to be that kind of guy. And then one day we admitted a guy who had an out of hospital cardiac arrest. Did extremely well. We woke him up. His neurological state was good. And he sat on the unit waiting for a cardiology coronary care bed. And then suddenly he dropped his blood pressure, went clammy, looked awful. And we thought he might be re-infarcting or, we're starting to think what we're going to do. And then we recognised he went pale and it was obviously bleeding. And we just assumed, gosh, well, it's going to be stress ulceration. People start teeing up the endoscopy unit, and then one of my colleagues who was a fellow at the time, he was my fellow, he'd also been on a free fluid kind of training course, and I said, look, go look at his heart, tell me what it looks like, and he said, it looks fine, and he said, by the way, I just looked, below the diaphragm, and he's got free fluid in his belly.
Oh, cool.
And he'd had a delayed splenic rupture, and we took him straight to the OR. At that point, there was no messing, straight in, cross-clamp on, and seconds after the cross-clamp was on, he arrested, we caught up, had his hyperkalemia treated, and he did extremely well. We woke him up when he came back like it had never happened.
There were some people out there listening saying, you sounding like old Ben now. Surely we've had that for years, haven't we?
But that's when I realised that this is not just, the abdomen is not just 3D, and it's for everybody. We've got to learn ultrasound of every bit of the body, not just the heart, it's the lungs, it's the abdomen, it's vascular, it's everything.
Yeah. Now, one thing that I love, and I don't know what the adoption here is in the UK, but I really feel like point-of-care ultrasound is really starting to take off in the US.
Yeah.
I mean, at all the meetings we've been, there's always someone talking about what we can do. And that really speaks to, we're looking at other organs.
Yeah.
We can do a lot.
Yeah. In fact,
that, when you say point-of-care, that means you whip it out of your pocket sort of thing? Or?
Pretty much. I mean, that you're doing it, and you can look at anything. I mean, that's my interpretation.
I totally agree. And, in this country, and I'm sure in the States too, that cardiology and radiology grew sort of at the same time.
Yeah.
And it's really difficult because those are very artificial separations in our eyes. The patients are the same, their organs belong to the same individual, the scanner and, the machines are the same. We need to break down those barriers between what's the heart and everything else, So that's one of the things we've been doing in the ICS FICE stuff, is to make it everything modular. So, you want to learn the heart, you want to learn the lungs, equally important, if not more important, in terms of decision making. Lung ultrasound,
Yeah, tell me a little bit more about lung ultrasound.
So differentiating a lung problem from a heart problem, is so straightforward with ultrasound. And in fact, a lot of my colleagues who I train with would say that lung ultrasound is almost more important than cardiac, because you can look at, you can see cardiac failure very quickly. Mm-hmm. You can see pneumonia very quickly. You can see effusions very quickly, and you can differentiate cardiogenic from non-cardiogenic pulmonary edema pretty quickly with minimal training. And so the yield is very high. We know that sensitivity and specificity is extremely high compared to auscultation and using a chest X-ray. It's right up there with CT imaging. And it can be done there and then, in the ED, in the OR, in the ICU.
I touched this earlier. I'm not meaning to be funny about it. Is there anywhere you've stuck your probe recently that you didn't expect to stick it?
I've been looking at eyeballs.
No, I thought
that's
eyeballs.
Crazy.
We've been looking at the neuro assessment of using ultrasound, and looking at optic discs is very, very good.
What can it tell you?
It can tell you whether there's raised intracranial pressure. And that's really useful when you're in the front door, and it's pretty clear. So it's something I'm developing, and we're all on a learning curve with it. Yeah. But so neuro ultrasound, that's my new thing.
Now, in our short conversation, and we went on for quite a long time, we covered a lot of topic areas. Yeah. We identified the fact that artificial intelligence is one of the hot topics. Yeah. Now, that means different things to different people. Yeah. But within that is sort of superficial and deep machine learning, algorithm-based practice. Yeah. You alluded, but we didn't have time to go into a deep dive, that in the ultrasound world, what we're badging as AI, some form of that type of technology is already here.
Absolutely. I mean,
can you give me some examples?
So, we're talking about lung ultrasound. So, if your lungs are injured or are congested with fluid, what you'll see are what's called B-lines. They look a bit like a kind of searchlight artifact running
like
from
curly B lines that we used to look on a chest X-ray.
Well, they might have to share the same B bit, and actually there's a correlation between curly B lines on the chest X-ray and B lines on your ultrasound, but that's just an accident. Heart
failure, echogenic.
Yeah. And so if you look at ultrasound, you see these kind of search beams from the origin of the probe right the way down to the very bottom of the field, and they move with the pleura, and they the more of them you see in any given sector, the more injured your lung is, or more congested your lung is. And if you look right the way from top to bottom, left and right, and it's congested all the way through, that's a strong sign that you've got cardiogenic pulmonary edema.
And is there's AI in that now? Is there?
So the venue,
intelligence
So for instance, the GE venue machine will look at that. It will identify the B line on the screen as it moves. It'll track it, and it'll put a line on it. and it'll calculate the number of lines in the field, and if you go through sequentially through different parts of the lung, it will give you a lung injury score.
So you're moving the probe and finding the window of acquisition. You hit a button that says tell me more, and it tells you more.
And so it'll look at those and track those B lines and count them for you. So it helps to quantify the burden of congestion or injury, depending on which bit of the lung you're looking at.
So that sounds cool. I'm still a little bit sceptical, but we're all early in learning. If you say it's true, I believe you. You must come and have a look at it. Give me another couple of examples, and then we'll come back and ask some other people to chip in with the conversation.
Great.
I mean, that's where we want to be. That's the future we want to be in.
Okay, well, there's another feature on the venue which is looking at the IVC and how variable it is depending on the respiratory cycle. So if you're a spontaneous breathing person, your IVC is small and collapsing, the inference would be that you've got low right atrial pressure, and likelihood for giving fluid and causing a problem is quite low. So we're starting to move away from sort of hypovolemia and talking more about fluid tolerance. Does that make sense?
But the computer in the machine is helping you look at the image. So it's rapidly analysing it and saying...
So you put your image on the screen, you get the IVC in view and long axis, and the machine will find it, and it will put calipers across it, and they'll be dynamic. So you'll watch that IVC change, possibly collapse or not, and it will track that and measure it and give you data on that.
Any more in there? Anything else we can do? They sound both cool.
So cool. So emergency doctors love the IVC. I think the intensive care doctors are a little bit more sceptical, I think, on that, and I'm not sure in terms of clinical application whether or not that's something we're going to be all doing, but it's interesting to show that what it can do, and I think we'll see more of this emerging. But the thing I really am excited about is that you can get the LVOT VTI data.
Right, so a lot of letters there.
LVOT, so left ventricular outflow tract.
Is that what we call the aorta?
Basically.
Okay.
LVOT is not the aortic.
Okay. Who's this new voice joined in? That is Dr. Sol Aronson, who knows a bit about
this. Who's nosy. Butting in again.
But for the masses out there, isn't it roughly the aorta?
No.
Okay.
So it's looking at so you're absolutely right, they're not the same, but it's the flow out of the heart we're looking at. It's a surrogate of stroke volume.
Big picture, it's the blood coming out of the left side of the heart. Is that right?
No, the blood coming out of the left side of the heart comes out of the aortic valve.
What's the left ventricular outflow tract?
It's subvalvular.
Oh, cool. Yeah. Okay. So what do you do with that then?
So the reason you're absolutely right, we wouldn't measure the LBT. VTI at the aortic valve because there's quite a lot of eddy of current and sort of flow acceleration as you reach it, so it can give you an overestimate of VTI. But what we do is bring the sampling volume just back a little bit, about 0.5 centimetre into the LVOT, and that's the point at which we want to measure the dimension, because if you know the LVOT dimension, you can then estimate the area of the LVOT, and if you know the area and you know the LVOT VTI at that point, you can estimate a volume, and that essentially...
Slow down. So VTI, velocity, time...
Integral.
So that is a pulsed wave Doppler sampling volume, which picks up just the velocity at that point, and it tracks it over time, so you get a trace. Do you remember that?
The area under the velocity
that esophageal Doppler thing?
I do remember very well.
I remember you seem to like that
one. The area under the velocity time envelope...
Yes, is equivalent to the distance that bolus of blood has travelled. That's the...
So you measure that envelope there. Yeah. You know the distance it's travelled. You've measured the...
Yeah.
And therefore you've got the volume. So you can say that stroke of the heart has produced 85 mils.
And if you measure the LVT diameter very, very accurately, you can get a pretty accurate, in fact, a very accurate estimate of stroke volume. And if you times that by the heart rate, you've got cardiac output. And there are studies to show that intensivists like us, with the right training, can actually measure cardiac output in a very accurate way.
Now, you're going to tell me that with the latest technology, if I get it kind of focused, the machine is going to do the rest to get it focused properly and give me that number?
Exactly. The problem is if you kind of try
Slow down again for a second. So you mean I don't have to get it focused exact, I can get it focused good enough?
Well, like I said, the measurement of LVOT diameter is difficult. Even experts find it difficult. And because you've got a dimension, you're then squaring it by the nature of the equation that you can square up and amplify error very quickly. So some people choose to not do that and just put in a number. Some people substitute 2 centimetres because on the whole aortic LVOT dimensions are 2, never less than 2, but usually not much more. But actually, what you could do is just do away with that altogether and just look at the LBTVTI, because it's a
tract velocity time interval.
It's a surrogate of stroke volume.
Yep.
And no, your aortic valve doesn't change, during the cycle. It doesn't change with too much pathology in the short term. So what you get is a trend.
Yep.
Okay, and actually, the venue machine will automatically, if you just press the right button, get the right view, it will find the LVOT. It will put a sampling volume on it, and it'll launch pulse wave to give you a trace beat to beat, and you'll be able to watch that, and you'll be able to quantify that LVOT VTI, and you'll be able to do interventions that may or may not change it.
So, Dr. Aronson, one of the first people in the world out of the block with perioperative ultrasound back in the day. What do you think?
I love your passion. I have flashbacks of what it was like when, if you put a mallet in somebody's hand, the whole world looks like a rock to crush. And so I appreciate so much listening to you. I would ask you, as you evolve and as we think about this, the strength or weakness of any echocardiographic index, albeit LVOT or VTI or whatever, depends on the company it keeps.
Yeah.
So why do you ask? Monitors work for us. We don't work for them.
Yeah.
So why are you asking the question that you're asking? It's a really, really important thing. So if you're asking the question because you want to know what the ventricular performance is, you should ask yourself the question, what is the systolic performance, what is the right ventricular performance, what is the interdynamic relationship between the two, what is the component of filling or afterload to the contractility, and those are fundamental questions that any hemodynamic query would ask. You can get there many different ways. One way is to calculate cardiac output, which I think is a very difficult thing to do with echo because it does require so many measurements, but you can just do a short axis, LVEDA, and just do an ejection fraction calculus by an FAC. Very simple. I could teach anybody to do that within 30 minutes.
So I'll let you come back in a second, Marcus, but on the specific ability of the computers to help us to acquire and make the measure we've decided to try and make, what it seemed when I watched all you guys back in the day is your ability to acquire that signal and make that measurement had such a degree of variability, I didn't know what I was coming up with. Do you think the computer's helping us to land? Let's not talk about the value of the measurement for a second. To land the measurements.
Yeah, I think so. I think it's important to know that the angle of incidence and just the angle of imaging is going to potentially conflate that.
I think we're saying the same thing, actually. I just, perhaps I'm not making it as clear as because I believe that although you can quantify stroke volume if you're an expert and you've had lots of training, actually you don't need to. You should be looking potentially at the stroke volume surrogates, LVOT, VTI, and looking at whether or not you have an indication of whether your intervention makes them better or not. And it's not necessarily about the quantification, it's the qualification of if you give a fluid challenge, does it go up? Or is it critically low that you've got to do something about it and get an expert to come in? Or
violently agree.
And put cardiac output monitoring on that you can do.
Yeah, I think it's fun to think about all the quantitative or semi-quantitative things you can do with echo, and you can. But that can be intimidating to the novice who's trying to get into this space. And so what I always do is I don't start there. I start with the simple things can get you very, very far. And over time you'll get skill.
I so agree with you as well on that, because whatever we're talking about here about stuff which is, intermediate echo, it's beyond basic and it's not advanced, and that has to be behind a competency wall. You can't just expect someone to go, okay, here, it's your first day using echo. Look, it's this great machine and it can do this amazing stuff. Because that is not the right thing. I think we're saying the same thing. I think start really basic. That's where the big wins are. I'm talking about stuff that where can we go next? When you've been doing this for a few years and you're really good at that basic stuff, what next? And that's where I see this coming.
So as I take away the three things that is there as a reality now using this type, we can argue about whether it's deep or superficial AI, algorithms, machine learning. If you're looking for signs of heart failure in the lungs, the B components of it, that's a reality.
Yeah.
If you're looking at what happens with the collapsibility of the veins, that's a reality.
Yeah.
And if you want to look at the left ventricular outflow tract and looked at the velocity time envelope as a surrogate for stroke volume, that's a reality.
And dynamic changes.
That's a reality.
Yeah. Yeah.
Oof, good. Hurrah. So, anything else coming down the pipeline soon?
Super cutting edge.
Well,
that's very cool, by the way.
It is.
It is
I was going to say,
cool.
this is
Were you
really,
involved in
really
developing
cool.
that?
No. I'm just receive it. No. But I suppose I really believe in it, and for me, one thing, if I could wave a magic wand, it will be that anyone who's done ultrasound anywhere they are can get an expert to look at that image there and then and give them the second oversight that they need, day or night, wherever they are. And that's the big...
Marcus, when did you pick up your first probe?
I watched one of my senior colleagues when I worked at the Brompton doing a TOE when I was supposed to be pressing on an artery that had just had a balloon pump taken out of it. And I remember looking at it thinking, that is the most amazing thing. And she was expert at this. And I watched it happen. And then I looked down and I realised there's about half a litre of blood next to my hand.
There wasn't what I was looking for.
That was the moment I realised.
What I was hoping
this is cool. That's not cool.
Yeah. Let Marcus answer that in a question. Yeah. What was the first TEE probe, transesophageal echo probe, you got your hands on? How long ago?
Oh, I remember it vividly. I went to the University of Chicago after my fellowship at Texas Heart Institute, and it was a diastonic 2200 machine. This was a machine that was bigger than a Sub-Zero refrigerator. It had a monitor that was about half as big as a small laptop, and it made the sound of a 747 landing without earplugs. And it created such heat that a cold OR would become, and the cardiac surgeon looked at me and thought I was absolutely crazy.
Monoplane, just a simple
monoplane, 2.5 megahertz transducer frequency.
Was it putting out heat and burning?
And the image looked like an old black and white TV set that was not, getting a channel correctly. Nice. And even with that crude, and the space has just evolved so much over the last few decades. God, decades. I'm talking about aliquots of time in decades now. My God,
this
I'm
is
old.
the last century. This all happened in the last century, Sol.
Yeah. The point I want to make, and the question, and the reason I asked the question is, wherever you are, however novice, however new, when you use ultrasound, it just makes you smarter. Now, you could be extremely stupid and be less extremely stupid, or you could be crazy advanced and be more crazy advanced. Yeah. But wherever you are, it just makes you smarter. And I think, and it's such a immediacy of return. It's not a high hurdle to begin to get that feedback. And that's why I think it's such a cool technology, because it's an ever continuous, if you will, progression to advancing your skill set.
I wish I worked with you as a trainee, because I really wish I was around people like you that helped open the doors for other people. And for me, I struggled sometimes because I worked at a time where the cardiologists weren't interested in helping anyone else into this world, and that's why I fight so hard to let other people move in. And that's why I think those boundaries are coming down in this country. Cardiology and intensive care and acute medicine are coming together in ways that they've never done before, and there's shared governance, and we've really the infrastructure here is extremely good, and I think we're going to see huge changes.
I would be remiss, and I have to do this because I have such gratitude to Dr. Steve Feinstein, cardiologist, who was my mentor when I was a young, wet behind the ears junior faculty. I didn't mean that. At the University of Chicago many years ago.
Dr. Aronson was pointing at Dr. Dick Burnham there.
and
name check.
I was just curious, talking about physician care, about compliance. And you need to understand volume if you've got to understand the physiology and biology of compliance. And there was a component missing in my ability to work forward into that sort of space. And that's why I became interested in ultrasound, because it accomplished the needed variable of looking at volume. And Dr. Feinstein taught me how to do this. And it was me being willing to hang out at 5 and 6 and 7 o'clock at night when they would read, and I would just, at the end of my day, go sit in the back of the room and look over their shoulders and listen. And it progressively became a relationship. That's how I started.
Fantastic.
No, I was just going to say, Marcus, I love your passion and your inclusiveness and wanting to bring everybody in. And I remember when we talked to you last year, that was just, I was so taken by someone that's so excited to share knowledge. And I mean, that's our mission too in TopMedTalk. So thank you. And good luck in all your ventures with, bringing everybody on board and spreading the word.
Thank you. Lovely to see you again, Desiree. And
you
too, Monty. And you too,
talk
Saul.
again soon.
Continue to make us proud.
Yeah,
okay.
absolutely.
TopMedTalk.
It's Desiree Chappell here. Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.